Thank you, Neil, and thank you for the opportunity to talk, and thank you to so many of you who contribute with your help to the work that we're able to do here, and that I'm hoping I can talk to you about if I can work the controls. You've just heard a very impressive explanation of the developments in epilepsy surgery, and my main interest is in brain cancer, which has for a long time been a bit of a Cinderella subject. And it's been very fortunate that the advances made in other fields, we've been able to some extent borrow their clothes in ways that I'll describe. I don't have a nice sunny picture of Queen Square, because normally when I come here it's cloudy, but I think it's a bit more jolly than Andy's one. This is the state of brain cancer surgery when I started my training in London. This is me doing my first ever procedure, supervised by my colleague from the private hospital in the background. And you'll see I even managed to get the wrong side done. And unfortunately, this actually was not quite like that, but brain cancer surgery was not viewed as important brain surgery. In many ways, it was viewed as something for people to learn their brain surgery techniques on, to get their experience, and that's because there was a general feeling of pessimism. And brain cancer is an awful diagnosis, by which I mean cancer that started in the brain. We don't have a cure for it, and survival has not improved in the ways that we've seen with other forms of body cancer over the last 50 years. And there's been a lot of debate about, is there any actual purpose in doing surgery for brain cancer? And
my husband's having an epilepsy seizure.
Sorry. Would you like me to continue?
It just gives you.
Sure. That's okay. This is one of the American pioneers of neurosurgery, Walter Dandy, and he tried major resections of brain tissue in an attempt to try and control brain cancer. And this is going back the best part of 100 years. And he found no matter how much he did, it would always come back. And what the slide at the bottom was showing you was how a small area of cells, of these cancer cells, will grow and spread. And brain tumor cells, they pirate the architecture of the brain. They creep and crawl down the wires and the vessels, infiltrating brain tissue, and it becomes very difficult to know where brain cancer ends and normal brain begins. And at the end of last surgery, Michael Lapuzze is one of the leading lights of American neurosurgery at the time, continued this view that surgery to remove brain tumors was effectively futile, and that the standard treatment of radiotherapy should remain, and the only reason for neurosurgery was to perform a small biopsy operation to confirm the diagnosis. And this is showing you graphically what I meant about how you have an area of tumor that might be visible, but how it will spread among the wires and veins through the brain. And this is a mathematical model showing the same thing. What you have at the top is the growing tumor that would be visible on an MRI scan. But what it's showing at the bottom is where the actual cells have gone to over the same period of time beyond the resolution of a scan. So you can see that if you were to remove this area here, there'd be a huge amount of cells left over. So this has led to an ongoing pessimism about the purpose of surgery for brain cancer. But to some extent it was self-fulfilling, because we didn't really have the tools to know if what we had set out to do in removing a brain tumor had actually been achieved. And as MRI scanning became more ubiquitous, it went from being a research tool to a clinical tool, and one that you could use on a regular basis. And we discovered a sad surgical fact, which was that if you asked a neurosurgeon how much of a tumor did you remove, and they would say, oh, I would think 95%. The truth was actually they removed perhaps a third of the amount that they reckoned. So people who thought they'd removed a lot of a brain tumor actually hadn't. And this reopened the door about, can we, with new technology, actually achieve a full resection of a brain cancer, and would that make any difference? And this has certainly been the drive that I've followed since I started in my practice. Here's one of my earlier cases. So this white area here is the brain tumor, and I thought I'd done a rather good job of removing it. And this is what it was like within a few months. So it's grown right back, despite radiotherapy, chemotherapy. And although I've shown you all those pictures about how far cells move within the brain, it's still the case that actually the great majority of regrowth of these cancers comes from where the original surgery was done. So can we really remove all the tumor that is present at the time of surgery? If you look at it, it does make a progressive difference. So if you can take out 3/4 of a tumor, you're going to start affecting the patient's individual survival. And each bit more you get at will progressively affect that survival. Now, you have to be a bit cautious about that, because the length of time we're talking about in additional survival is not long. But when a patient has got a short survival time, it's very important to that patient and their family, particularly when it's attached to maintaining quality of life. It was as important, if not more important, than duration of life, if this is the trajectory we're following. So this is what we're able to do here now. These are the real advances in recent years. When you operate on a brain cancer and you get into it, it's very clear what is abnormal tissue. And then you take that all away, and what you're left with is what looks like the brain. And you'll have to take it from me that this is what looks like the brain. But if you give patients a compound that is metabolized in cancer cells, that compound produces a byproduct, and that compound will glow purple under a blue light. If you shine a blue light down that hole, you see what's been left behind. And this is revolutionary from the point where I began. And you can add that now to the operating MRI scanner you've just been hearing about. And if you put the two together, so a similar case to the one I showed you before. This is a recurrent brain tumor this time. But this time, before even taking the scan, I used the blue light, and you can see there's a clean margin all the way around. And you can use the same techniques that we're pinching from our colleagues in epilepsy surgery. So we use the same functional imaging to show where function resides, where tumor resides. We can look at the same thing with the tracks. That same thing, because whilst it's very important to take out as much tumor as you can, if you injure your patient, you undo all that good work. So you have to tailor your procedure to each patient. Is it really feasible to remove as much as this? And with this functional imaging, you get a lot further forward. The navigation system that Andy showed you actually was a spill-off from the end of the Cold War, where the missile navigation technology came to us. I think we put it to better use. And you incorporate everything together, and you think you're probably able to get it out, and you can do the ultimate test, which is you can have a chat with your patient during the procedure and check that you're not causing harm at the same time as checking that you're getting everything out. And this gentleman here is showing you it really isn't as bad as it sounds. So I mentioned that it's potentially small gains if we take everything out, but actually I think it will turn out to be much more than that, because the cells that are in that edge population are not the same as the cells that are spread widely throughout the brain. So if we can reduce the local recurrence of these tumors, it will give us a window in which we can add in the new therapies that are emerging just now. And there's a lot in the news recently about immune therapies. And one of the huge benefits of working in an institution like this is our close link with the university and our oncology colleagues. So we have going on here trials in immune therapy. And I think the combination, the ability to use all the technology that we have the privilege of having, careful patient selection, achieving maximum resections, and the new therapies, we might finally see a real change in the outcome of this disease. Thank you.